So we're going to be talking about radiation safety today. We'll be talking about some sources of radiation, exposure and dose, and specifically about dose limits and estimates of risk, and looking at some methods to reduce the risk to both ourselves and our patients. Our goal is to keep the radiation exposure to our patients and ourselves as hygienists and operators to meet diagnostic requirements. So we need to take the films, the exposures, for the diagnostic purpose of our patient to help come up with a treatment plan, but we want to keep it to a minimum. And our basic assumption is that every dose of radiation has some potential, and you can see that I italicized that, for biologic damage, realizing that we talked about a lot of factors, that the body does have repair mechanisms, and that X-rays are rather a weak source of energy release over the course of the tissues. But we still have to assume that there is that potential for biologic damage. So it's like that balance that's showing up on that right side. We're tipping the scales between the risk and the benefit that's going to be gained from our improved diagnosis and treatment. And the efforts to identify this balance have resulted in the development of standards by various national agencies. So our sources of radiation come from two different groups. One would be natural, and the second one would be artificial. I know this pie chart is really hard to see, but I'm just trying to and you don't have to know the percentages down there, so don't worry about getting a magnifying glass out this weekend and trying to see that, okay? Just want you to know that there's many sources that go into our natural radiation exposure. And it happens to be our largest contributor. If we look at natural versus artificial, natural is more of a contributor to our radiation exposure. And breaking natural down, we have both external and internal sources. We'll talk about that here in a minute. Cosmic radiation, so that's coming from the sun and the atmosphere, contributes to about 8% of our total annual radiation exposure. Again, the figure is not important. I'm just showing you the different groupings and showing you how much of the slice of the pie it contributes, but it's not something I want you to memorize for the test. I'll try and let you know the things that are important today to study, okay? You also get some radiation exposure from the ground based on the type of soil, and that's also about 8% of the annual effective dose. If we talk about radiation, there's many ways to measure it and compare it, and I'm a firm believer that a picture is worth 1,000 words, or even trying to make. Also, 1 in a million risks of death due to smoking 1.4 cigarettes due to cancer and heart disease. I found this one appalling. 30 cans of diet soda due to chemical carcinogens. Because I thought about all the cans of diet soda I've had over the course of my lifetime. Oops, I'm sorry, let me come back here a second. So I'm probably like 1 in 10,000 by now, you know, risks. Or here's our full mouth series and panoramic radiograph, and it would be due to cancer formation. And that's because our dosage is approximately at that point 1 millisieverts. And again, though these are kind of odd statistics, this was determined by Department of Energy radiation worker training based on this work by Mr. Cohen. All right, so the recommendations from the National Council on Radiation Protection have led to establishing a limit or a maximum permissible dose, abbreviated MPD. And by definition, this is the amount of radiation that an individual is allowed to receive from artificial sources of radiation. And this is highlighted, and this will be a good thing to think about for next week, except when they are a patient. And the dosages that they came up as the maximal was set because they were not expected to produce any significant radiation effects. So low that they expected the body to be able to undergo their processes to correct for any radiation damage. So again, this is based on the statement that was highlighted in red. The radiation that's necessary for medical or dental diagnostic purposes is not counted against the MPD. So this is a maximal permissible dose for you as dental hygienists and for me as a dentist, okay? But they don't take into account that we too are patients and have to go get dental and medical treatment done. So these limitations address the fact that the ability of cells to repair radiation damage, as I mentioned, different radiosensitivities of the organs, and they consider that at this dose that no radiation effects will be produced during our lifetime. It's interesting that rectangular collimation is encouraged because the field of exposure and absorbed dose is decreased, and this is from the National Council on Radiation Protection Report 145 that came out a few years ago. There are ways that if your tube head is not rectangular in shape, you can actually clip these on the round end of the tube head, and this helps it become the rectangular collimator. Most units will have, or not most units, but some units will have the ability to swap out these beam indicating devices. So you just unscrew them. So you unscrew the round one and can then go for a square collimator. Long cones in the range of 12 to 16 inches will reduce the divergence of the beam when compared to short cones. So you get less geometrical problems, and it reduces the field of exposure. Kind of the way it goes. Okay. So the use of a leaded apron is not necessary and not the law if you follow all of the radiation protection practices. But it's going to protect you from criticism and patient anxiety and so on. There's also the option of using this little thyroid collar, and this is where the NCRP report was pretty strong in its suggestion, especially for children. The reason we use the thyroid collar is that the thyroid is one of the organs or glands that tends to be very radiosensitive. And some studies have shown that by using it, you have 92% decrease exposure to the thyroid. We have protective barriers of shielding. Our walls downstairs are lead lined in the radiology room. That's why we make you, and when the button switch is such that you have to come outside the room and look through the window, again a leaded glass window, to press the button. Some offices or some situations may not have a protective lead room. So another way you can help reduce your risk is to stand at least 6 feet away from the radiation source. Sometimes you'll have these little movable barriers that you can put in place too. But very importantly, you should never stand in line with the primary beam. Most of the dental offices that you'll end up working in, if you ask about the walls around in the room for the x-ray unit, they aren't going to have lead per se, but they have to be evaluated that the material that the wall is made up of has a lead equivalent of so much thickness. So even drywall has a specific stopping power for an x-ray beam. So don't be concerned if you go into an office and if you ask, are these lead protected walls, and they say no. Okay, so they're going to be evaluated. It has to be tested before the x-ray unit can operate.